So I'm asked to comment on surprises that we've had in the field of atherosclerosis and lipidology in recent years. And I think that one of the real transformations that reflects how in scientific medicine we have to be flexible and change our preconceptions and most cherished notions based on evolving data has to do with the role of high-density lipoprotein as a putative protective factor in atherogenesis. It's clear from my writings and my thinking maybe a decade ago that I absolutely bought into the hypothesis that HDL was a protective factor against atherosclerosis and that raising HDL would confer clinical benefit. But we've had to confront both human genetic studies and clinical studies that have cast enormous doubt on that proposition. First off, there have been probably 3 different avenues for raising HDL in human patients that have not proven beneficial in terms of outcome, and matter of fact, might even cause some hazard with some of the agents. And on the other hand, there's been this snowballing human genetic evidence that suggests that if we inherit haplotypes, if we inherit variants that give us lifelong higher HDL, we do not benefit in terms of reduced cardiovascular events. And on the other hand, a whole series of mutations, and there are at least 4 different types of targets for these mutations that can raise triglyceride-rich lipoproteins, are associated with adverse cardiovascular outcomes. So I think that we sort of missed the boat. We know that triglycerides and HDL tend to vary inversely, and we focused on the HDL as the causal part of that dyad for decades based on the persuasive evidence from observational epidemiology and also a mountain of preclinical results from laboratory studies that suggested that HDL particles could be beneficial, not only because of mediating reverse cholesterol transfer, but also because of anti-inflammatory and other kinds of wonderful benefits that were demonstrated in vitro and experimentally in animals. So I think that this has been a real shift in my own thinking where I think we missed the boat, that the causal part of this dyad of triglycerides and HDL is the triglyceride-rich lipoproteins, not the HDL. Now, it's clear that HDL is a very complicated particle, and we have still much to learn about the functionality of subclasses of HDL and some of the fellow travelers that are packaged with HDL. But certainly the concept that just HDL cholesterol is protective for atherosclerosis, I think, does not fit the data that we've acquired. And that, I think, is positive, not only because it reminds us to be humble in our medical thinking and scientific thinking, and to always be open to new data, but also because it identifies the triglyceride-rich lipoproteins and the remnant lipoproteins as novel targets for intervention. And so we have a way to pursue perhaps a more productive path towards event reduction than the dead end that we've encountered with modulation of HDL.